don't.
Feel free to take a seat. Yeah.
You're okay? Yeah. Thank you for
Jacqueline was
coming.
as well.
I didn't know for a fact, but I had texted her.
Good.
Good.
I asked no calls, I got another call, it's a message. Who's asking us to talk about calls with their week?
Also.
Whenever, sorry, I was just
Go
getting,
ahead.
okay. Good morning, everyone, and thank you for coming. Yes, at the last minute and I'm early here. So we're here to follow up with the treatment court evaluation and the direction that we were given by the board from the last workshop that we were at. And so my computer works. Yep. Okay, hang on. Let's try that one. All right, here we go. So this is just a brief recap of the last workshop that we did and some of the highlights that were from the third-party evaluation completed about the treatment court. What we found out through that evaluation was that 86 adults were served by our Scott County Treatment Court since it started in 2016 to 2024. So it averages to be about 10 to 11 people a year. The people that were in this particular study, there was a comparison group of folks that were on general probation as to analyze against. The average caseload size for our high-risk probation caseloads tend to be around 30 to 40 a year. So what we found out was that we can serve more people on general high-risk supervision than we can in our treatment courts. We also found out that in recent years, we have been denying over half the people that are referred to courts, and so we're seeing that higher denial rate. And when comparing those that graduated from treatment court compared to general high-risk probation, especially at the 2-year mark, we're seeing similar results. And so we're finding that the message that I really hope we've conveyed thus far and continue to today is that treatment court is a great program. It has been a wonderful program for Scott County, and they exist across the country for a reason. And what we found out is that we're just also doing well on probation, and that's also good news for us. The philosophy of probation has shifted a lot over the last 20 years. And so when treatment courts were stood up in the late 80s and the 90s, probation looked a whole lot different than it does today. It used to be a very kind of a tail them, nail them, and jail them, catch them doing wrong, lock them up very quickly at times. And we have shifted to an approach that does look a lot like treatment courts do today, where we're working really hard on the balance of accountability with the rehabilitation and really working as a community around providing resources to clients, just as treatment court does, so that people have the best likelihood of success in changing their lives in general. So again, I want to reiterate that these are both good programs. I'm happy and proud of the results of both of them. And we do know that treatment court is a very expensive program. And if we can serve people and in a similar way and have similar results, then that's what we are striving to do. So what happened after the last board meeting or workshop was that we were asked to do these 4 things. I was going to go back, and I did, to work with our justice partners, not only to share these results, but to have conversations about what could an alternative program here in Scott County look like for a reduced amount of money, but also serving this population. So that is I'm here today to walk through what that looks like in the conversations that we've had at different points along the way. We definitely want to include, and that was important, that the current participants, we have a plan for them. They agreed to this. This is a voluntary program, and we certainly didn't want to upset their trajectory being in treatment court. And was there any unintended or fiscal or other kinds of service reduction consequences that at least we could see at this point if we were to shift to an alternative probation program? And so I met with the various people on these particular dates. So on the 14th of January, I did meet with the treatment court team and we reviewed the evaluation and the results. We then had a smaller meeting with the 2 judges of treatment court, with our court administrator, Jennifer Everett, County Attorney Ron Hosevar, and Chief Public Defender Lindsay Sayoka. And then we also met as a Justice Steering Committee on February 6th to discuss, again, the results of the evaluation and what alternative programming might look like. So there was agreement with the various groups of people that we would like to transition from our current model, Scott County Treatment Court, to 1 probation officer that would continue to do enhanced drug supervision caseload. That we would, through our assessment process, usually at the pre-sentence investigation time, we would identify those that are highest risk. We have lots of people on probation, right, for drugs and alcohol and different things. So we do need to figure out through our assessment who are the highest risk individuals that would need this type of intensive probation supervision, very similar to how we determine if people are right for treatment court. And we would like to continue drug testing and providing some mental health services to support this caseload by shifting some of the program costs as well. In addition, although this is not about Veterans Court, in particular, what we do have is 1 probation officer that is the coordinator for both the treatment court and the Veterans Court. On the Veterans Court side, we're working on expanding into the First Judicial District, so it's to support all the counties within the First Judicial District. And so what we're asking for is to shift the coordinator position from half and half to 1 full-time FTE for Veterans Court. That you'll see here, I'll go through the fiscal implications of that, but we get state funding for that position. So that is not being asked for any levy support for that. That would just be to utilize the state money for the state position that would support the First Judicial District. So what we're asking to submit for an RBA, the next board meeting or whenever you would like, is that what we see in the first column there is our 2026 budget for treatment court. And so right now we have a total expense of $425,683. And what we're suggesting is that we move that 1 field probation officer to that 1 treatment court probation officer to the field budget. And then we're asking for a small portion of the mental health services and the drug testing and EHM expenses to be moved over as well. So we're asking for the $181,100 to go into the community corrections budget. As you can see, we can offset the program expenses. We get more dollars from the state than we're spending in those program expenses. So it definitely supports that full-time vets court coordinator. So we would not be asking for any additional money except to just shift that in vets court. And then what that would look like is the $142,183 that would go back to the levy. I forgot to mention in the transition to the field, the other decision that would need to be made is whether the $152,500 opioid dollars would shift to the field budget. They are being used right now in the treatment court budget. If we did shift that over to support the drug caseload, then that's what the dollars would look like moving over. So that is the ask, or the, I guess, the analysis that we did. And I will stand for questions or comments.
Molly, the transition to field, moving that money to field, what's that going to change? in your program? Like, is it going towards the current budget? Is it, tell us about that transition to field, the money going to field.
I understand the question. So we'd be taking the money that's in the treatment court budget, and we would say, because that's a caseload of people. And so we're going to keep the probation officer, the caseload, and the type of supervision that we provide in treatment court, and provide that same higher level of like dosage and intensity that we do now on general probation. And so we're just asking that we keep some of the money, but it won't be as expensive as running the treatment court budget.
So that was our staff recommendation, continue to use the opioid dollars that we're gonna shift here anyway, and then put that back towards the general fund.
I'm surprised to hear that you're getting similar results, because my perception is that these individuals, the 10 or so a year, were really surrounded by a team of tailored to the needs of different categories. I'm assuming that rather regular probation, they don't get that same team surround. Surprised that you're saying it's
I think it was surprising to find that out, although that's where I go back to, yes, I do not want to say that they're the same. They're not, they're different models. But I will say that we're working on similar things with individuals. We're working on in general probation, we're working on mental health, we're working on substance, and so even though it's not the like showing up to court all the time, it's certainly other community partners. It could be Damascus Way, it could be, again, any of our community CD treatment facilities. We're still going to see them at the home. We're still going to see them in the office, right? Cognitive behavioral programming is provided. So we're doing, again, not the same, but very similar. And so to me, what is exciting is, again, they're both doing well, like treatment court's doing well and probation is doing well. So that to me is good news and a decision to be made on whether or not we continue doing treatment court, or if we can do this and have similar results and serve more people on general probation, then great, right? That's the, to me, kind of the win-win, if you will.
I think the connect there, at least, and I've probably heard this a couple of times now because of steering and other things, is 10 years ago, general probation didn't include all those things. And now it does. So I mean, yes, 10 years ago, it was different results probably. Yep. When we started, and now it's not. My next question though, especially with Chief Pearson here, when we talk about treatment court, we often hear about the curfew visits, the relationships with the law enforcement, all that is, and again, we assume that contributes to all kinds of good things. How will you consider that or use that with this more intensive caseload, or how is it, maybe it's already being used in a way that we just don't hear about? Thoughts?
Do you want to, and then do we need to?
Well, I mean, we haven't had any formal conversations about what that looks like. You know, my hope would be we could some way, or I should say probation could some way utilize law enforcement so we can continue to build and make the connections that we have through treatment court. Now, we're talking about a very small population, so, and when you look at this from like a 10,000 foot view, are we impacting a whole ton of people? We're not, but the impact that we have had on the small number of people is gigantic. And I could tell stories after stories after stories of the connections that I've made. But I'm one of how many cops that work. So I think there's definitely ways that Molly and I could brainstorm where does law enforcement fit into this, and do they need to?
Yeah, ideally, I'd love for that to happen, because it could be actually even a better situation where before that was limited to those folks in treatment court. Maybe there's some criteria or some research, some learnings where this certain population of general probation or high risk probation would benefit most from that, and from that kind of law enforcement partnership. And maybe there's some opportunities for that. I hope you find people who are smarter in this arena than me, find the best population for that and use those resources, because I think it does other things too, that partnership.
I may misunderstand the process. My perception is that in the past, someone said, either go to treatment court or you're going to jail. Is that true?
Yes.
Okay. So you're saying probation is getting similar results. Well, these people that are going to go to treatment court are going to jail, then probation, right? Or no?
So now, thank you for the clarification. There also has been some laws that have changed, especially in the drug charging. So there's not as many people that fall into that category of commits to prison or treatment court. So there is a lot more people on treatment court that aren't in that scenario. Quite frankly, they could be on probation. It wasn't a mandatory, again, sentence to go to prison. There are a few. And Lindsay Sayoka and Ron Hosevar, when we were talking about that, have ways that they can still negotiate that, knowing that we have an enhanced drug caseload as well. So it doesn't mean that that conversation and that like a plea deal can't be met in the same way that it is now. It just might sound or look a little bit different. But so you are correct, and there's been shifts along the way, and there's still a mechanism for that to happen and for a departure to probation in cases, especially where people are motivated to want to change their lives. So we won't necessarily see more people going to prison. That was one of my concerns about sunsetting treatment court. And it doesn't feel when we looked at the numbers that would necessarily be the case. We also have people that were not referred to treatment court that the county attorneys have negotiated departures to probation anyway, that were in that sample as well. So again, there is a space for that we don't foresee having that negative consequence that we kind of were wondering about in the beginning.
Good question.
Yeah.
So just to clarify, so my simple mind, it's like before it was like go to be incarcerated or go to treatment court. Now it might be go to probation on this with this type of restrictions, high risk caseload, or go to incarceration. Same thing. So we're just negotiating a different name there.
Similar, we decided not to, it's not a program like treatment court though. So they're gonna go through the same process that anybody is placed on probation. So they would be arguing for departure based on statute.
Okay.
We would then determine in probation who is of the highest risk of all of the folks and put them onto this caseload based on internal assessments.
Okay.
So really it would be between the state and the defense to make a decision, or the judge to make a decision about, again, is this person amenable to probation? Do they have, right? And then we would, doesn't guarantee that they're on this caseload, no. Because they don't know out of the thousands of cases coming through, which are the highest level. So it's not a program like that per se, but it would be that we still have, if they don't end up on this enhanced drug caseload, we have a lot of other caseloads that are high risk supervision that will take care of the rest of them and do very good work. They might have a slightly larger caseload and not have necessarily the drug testing money as an example, so clients pay for that. But it doesn't mean that we're not doing the work that you're seeing actually in this comparison group.
Okay.
We don't have that enhanced drug caseload now.
Okay. Thank you.
Molly, you said Judge Lennon was gonna maybe try to come, do we know what her comments were, or did?
I was just gonna see if she ended up responding. No, when I did have a conversation with her, and this isn't just her, I think it's happened, I do want to honor that the judicial board in the state of Minnesota does have in their strategic plan that they want to stand up treatment courts like all over the state. So I just feel like I'd be remiss if I didn't say like that piece of it. I also think that there's jurisdictions out there that are looking at these programs to say, have they, what is the word? Like, have they exhausted their time? Like, they were good for a certain period of time, but if we're continuing to change how we do work in probation to rise to that level, do we need it or not? And you can only answer that if you do a third-party evaluation. I'm very cautious, like, don't say because what you see here in Scott County, it means it's happening for you. That's why these things are so important. But it may be something to look at as we decide how, I mean, again, they're expensive programs, good programs, and, are they good for your particular jurisdiction? That would be obviously up to the body of people to answer.
Well, it feels like this program, that was always the rub, right? High cost, low pool, generally speaking, but the times when you saw, I go into the courtroom for the graduations, court was in session for treatment court, or chief in her former position, you know, at Deliberate What Matters or whatever, you could see the participants like stand a little taller because somebody was kind of coming down to their level, so to speak, and speaking life into them. So it's like, okay, how do you do that? Because that seems to be less programmatic and more like what drives a person to do that, to pour into another person. I mean, there's a heart to calling for that. So yeah, the program itself is like, okay, it has some constructs where it puts some of these things in collision path with one another, but if you don't have the heart for that, or you're one cop out of many county that has that heart to do that, that to me was what was the difference maker. Where you'd see a judge come down from the ivory tower and speak to these folks and like, whoa, like, wow, you see something in me and you can hear their spine, at least a little taller, maybe not, but. So how do we do that? Is this program, because when did we do this workshop where we looked at those, where the numbers were like almost
Same.
indistinguishable?
Yeah, they were the same at the 2-year mark for sure. At the 1-year mark, they were slightly better for treatment court, but very similar, again, in the single digits. So, I agree with you. I think that the heart is important and all those sorts of things. I hope that my agents have that because that's really why they do this work in the first place. When we do cognitive behavioral groups, for example, we do graduation ceremonies during those. And I've taught those in the past and clients have the same kind of responses they do. It's an accomplishment of achieving things and programs, whether it's treatment court or again, these cognitive behavioral programs that really is rewarding the behavior that hopefully they want for themselves intrinsically and that we're looking for extrinsically. And I think that we're finding that meaning elsewhere as well. Again, that's why I said I think they're all good programs and we're finding similar results.
Yeah, we're not usually in a situation where we're letting go of something that's good, right? Like we found like this is good over here. And then as we found probation is as well. So we're actually just trying to find the more cost-effective way to get the same results.
Right.
And that's challenging to let go of something that has been successful too. So.
We heard something this morning, statement, what do we keep? What do we stop? Or do?
Yeah.
It's always hard to stop doing something.
Absolutely.
Big thing for me as I look at this isn't stopping doing something because it wasn't effective. This is, we've taken the lessons learned from there and other things about the touch points we have in our system and said, no, this is just how we need to operate for this entire population. And that's why we're stopping. It's not that it's bad and going away and something that we're also bad at doing, something that doesn't, maybe not us, but government. But we've incorporated those lessons and now we're doing that more broadly because it's no longer a pilot, it's just how we operate.
And with the subject matter experts that I mean, this is a group where it's like, we always talk about, you're coming to do a job. I don't know if this is all that you would do to come to a job. If you're trying to live out your calling, yeah, this is probably a group that you can do that in. So I coming at it, but generally speaking around the room, believers in making this move. And it's okay to have, because the next question is going to be, are those, are those that like, I'd like to hear that too, because I think it's a good conversation.
Let's know what we're giving up.
Right. Again, that's why I wanted to honor the voices that aren't in the room that I did hear. So as an example, Lindsay Sayoka would say that she was worried initially about, again, would these departures happen? Like, would more people? And through that conversation, we don't believe that's true. Again, because the county attorney's office does this for other people. So you just present the case and work the case like you would normally. The judges, I already commented that they do have this strategic goal. So it is hard to see something sunset when you're hearing in the background that we want, jurisdictions to stand more of these up. I will say that when I met with Judge Weber and Judge Johnson, they also looked at all the data and said, but I can't argue this. Like this, it makes sense. And so I don't think people are happy. Like you said, it's hard to see something sunset, but I would also say, Sam is still going to be Sam and doing the work with these folks. Like that doesn't change. We can still go back to court to a judge and ask for the things that we ask for in court. I can still go to law enforcement. We do now. If we have a home visitor, we need some help. Law enforcement is great in general probation. Yes, we can explore unique other, pathways to make that even stronger, but I would say that we do some of that, maybe not formally, like in treatment court, but those partnerships still exist. And so I just want to keep doing probation work really well so that we continue these results.
I have this question in my mind, just wondering what the judges would say that were in the ground floor and found it. What would, if they were here, what would they be saying?
Well, I think that's what you're getting at. Judge Lennon did say, like, maybe they've run their course. Maybe maybe probation has caught up essentially to this work.
That was one of the ones that said
I don't know. Yeah, so okay, Lennon was one.
Judge Wilton, is that?
Wilton
He was the other one.
Judge Stacy.
Judge Stacy.
Rex Stacy. That is, they lost somebody. They lost somebody. Well, yeah, that's right.
Yeah, are we at a spot where it feels like, sure, the state is saying that, or whoever, the state wants to stand for more of these, we've sort of gone down that road. And this feels like a better option, because my whole thing, like, big believer in you can get better outcomes with the power of hope and transformation and all kinds of things. Talking about this now. But with the power of hope and transformation, we can get better, collectively get better outcomes and at a lower cost of doing government business. Like, it feels like maybe that's where we're at, which is a great place to be, which is what I think where we're trying to hope to be, right? With all the things we want to do as a governing body in this cute little adorable Scott County.
I think that's exactly what we're trying to say, right? You've asked us to run programs. We have run this program. It has shown some success. I think it has modified the way probation, some of these specialty courts operate. We have changed that operation. And we feel that these folks over here can get the same results, if not better, over time with running that type of a program and still save $1,000. And so we wouldn't be here recommending it if we thought we should still be running treatment court, because the board didn't say close down treatment court. We did the evaluation, which you've asked us to do. You're going to see 3 more of these come before you this summer on programs that we're.
That's great. It's a great
And
place
so
to be.
it's what you've asked us to do, run programs, measure the outcomes, look at the data, and then make recommendations.
Great place to be.
One more. And again, you have to fill me in. Veterans Court, why is it different?
I don't know. We haven't done a third-party evaluation, first of all, so I think that's the unknown. We will need to do that at some point. We recently, it may come back the same and it may be different, and I don't know. We'd have to dig into, like, if there is a difference, what that is and what makes that different than treatment court. So right now, because we've more recently combined with the First Judicial Court, we need to give it some time to work, to be a program for a while, just like we did with treatment court. And then work again that evaluation in and have similar discussions and depending on what we see as a result.
Colleen, when did we officially start veterans court? A little year and a half ago?
Yeah, that's what I would want to say.
Yeah.
Well, we started it,
In the format where we're.
Oh.
That we're at right
operating
now.
As a true veterans court, right?
Right,
We're
year and a half.
funding the program.
Well, for the joint, I mean, we had
Yep.
like our best courts back to what, 2020?
right, yes, with the federal
refresh,
grant. And then, yes, about a year and a half ago with the First Judicial Court. Yep.
Yes.
I just asked to understand better. I'm not
Yeah.
making.
It's a good
policy
question.
Recommendation.
Yeah.
No, I think that's what all of these programs, it's important to do that evaluation.
Yeah.
We're just not ready yet, which
Yeah.
is my hesitation, yeah.
So are you looking for the commissioners to state the?
We'll just support for it. That would be our recommendation to move forward with the process. And, how we sunset it, begin the budget allocation to the corrections. It should come from there for the office, some of the supports. We don't even know exactly those dollars, put enough in there to do it. It could be even a little less, could be a little.
Is this RBA or the resolution for April 21st, you're planning on consent or doing a short presentation?
Whatever you
Whatever,
like.
yeah.
I think a short presentation.
That's my bet too. I mean, it doesn't have to be the whole thing, but it just makes it more transparent.
Happy to do that.
Sounds pretty comfortable.
And the other thing I'm hearing you say is to work with law enforcement to see if there are some opportunities, just in our probation practices, to work with that type of support. I think that's the main thing.
Yeah, I think we have a very good relationship as it stands. And I think it would just be kind of fun to come up with some new ideas on how to kind of implement us in this process, this patient process. And it may work and it may not. Maybe we're stepping outside of our lane. You know, probation is probation, law enforcement is law enforcement. I fully recognize that, but I think these connections are really important and valuable for the officers that are willing to make the connections. So if there's a way to partner on something or come up with one creative idea, I think that ongoing conversation certainly continue.
I agree, absolutely.
I do think there's a lot of opportunities for that. To find a efficient,
Mhm.
good way to do it. I mean, again, for much broader community and partnership.
All right.
Right. Thank you very much.
Thank you.
Yeah, thanks.
Thank you.
This one's.
Well, the whole board is not talking. Talking about this.
I mean, there's time.
Of course, I'm fine not being.
Yeah, I have some documents for you. So,
Thank you, Chief.
have a moment.
My signature is 14.
Oh, I don't.
The other pen? The other pen.
Guys, say the same thing at the same time. Oh, man.
They say signing your name over and over builds confidence in stressful situations. I'm going to make you very confident.
Yeah.
This is dispatched to provide this agreement. I've stickered everywhere to sign, and then I have 3 copies here. Chloe.
I think Ted told me to break.
Yeah. This is not a break, but Jody took a little break.
So what do we? Nothing.
You're signing stuff.
No, I can do more than one thing.
Multitask.
Okay,
You
so
can go right
well,
ahead.
Do you want to wait for Commissioner Brennan or go ahead and move forward?
No, we'll wait.
Free versions.
no, thank you. Right, I'm sorry. That's what I should do. But yeah. We would let them like. All right, Jody's back.
Yeah. Okay, all right. So here to present on the scale feasibility study results. This was presented to the Scale Services Committee a few weeks ago. As part of this, and the reason you're seeing it this time, we also have our health insurance renewal information. I just want to note, like, that is really intended for just informational and contextual purposes. for this. We have the data, but we haven't gone and had a formal recommendation from the Employee Insurance Committee yet. And so that's still to come. So this is just more informational purposes. So we have seen this graph before. Pools, trust coalitions based on the Arthur J. Gallagher Company shows that it typically beats the medical trend overall for being in these sorts of pools.
No.
Yep.
This triggers my thought. I'm still wanting to see the comparison.
So we have
provided
some of that.
with the counties.
Yep. We
Not
have,
in a graph, but in the percentage for each.
we have that in this presentation.
Good.
Not all the counties, but a smattering of them. So the idea here is that the place where these consortiums really have the saving is that pooled claims layer here we see where there's less than insured stop loss, there's administrative saving, professional services savings, and then our claims costs are more fixed, and that variability is handled by the pool overall within the insurance pool. So the feasibility study results, and I'm showing a little bit more detail than we have in the past because we've started to see these slides. So I wanted to show some apples to apples, but we have medical claims history data, prescription drug history data from all the members of the pool overall, and the total pool would experience about a 12% increase in their health insurance rates, but that's different based on each entity and what they would see. Our standalone calculation for Scott County without being in the pool based on this projection is this bottom number of an 8.6% increase for health insurance. I'll note the slides you're going to see here in a little bit when we do our renewal shows an 8.3% increase. That difference is due to some of the assumptions they made in the pool for some of the fees that you see down at the bottom. So they haven't gone out to market and said, what are the fees going to be for this entire pool? We do know exactly what our fees would be for these renewals. So that's where you're going to see a little bit different number. So it's saying we would be at an 8.6%, and that being in the pool would be down to an 8% based on the makeup of the pool. So when we look at that for all participants, so this is all the ones that have been included in the study over here on the left, Scott County I've highlighted in yellow. Our increase would be 8%, so 6% below projected. But overall, they would say in general, the pool would be 6% lower than they would be without being part of the pool. And again, each entity has its own different variation based on what their specific claims data information is and their current rates. And you can see Carver has a pretty significant variance within here. Shakopee has a pretty significant one. Elko New Market does. So some of these smaller cities, I will say the smaller cities data isn't as solid because they don't have the specific claims data. So that is an assumption based on their population data that they've brought in there.
So I'm still distracted. Say again what the variance means.
The variance is what the difference between the expected increase in our claims. So if you see Scott County, we're highlighted here at 8%. From being in the pool with all of these participants, if we were not in the pool, their projections would have us at 8.6%. And we asked them to run a number of different analysis on this. So the next one includes everyone excluding Scott. You can see that the variance actually goes further, 7.8%. What that kind of anecdotally tells me is that we're a drag on the pool a little bit. So we're benefiting more from this. Because of our claimants and our claims history.
Funny how Jordan's been such a big proponent, and it looks like this isn't gonna help them very much. Interesting.
And again, it's not about the 1
1
year
year,
picture
yeah,
as much as the
right.
long-term trend.
Now,
And
how
one of the
realistic it is that Carver, Dakota?
I think Carver is very interested in this.
Numbers?
Yeah.
From what
Well,
I've
the
talked,
difference between very interested and being able to pull the trigger at the time when you're talking.
I don't know about their feasibility on pulling the trigger. In conversations with some of their ER folks, they have been looking at going self-insured. They actually like the idea of a pool as opposed to going self-insured because it's not just them on their own. It is a group making the decisions. They felt that was a better middle ground as opposed to going from fully insured to just self-insured within there. So, but specifically with their percentage change, they're, I think, even more interested than they were before. But this was something that they were definitely interested in before we even had the feasibility results. So the next one includes Scott County, but doesn't include Carver or Dakota. So we would actually, under this scenario, see a little bit of an increase in our rates for the 2027 year. Really those large employers, again, why the cities are interested, helps to pull that down because there's more people to spread out that risk in those claims overall. And then we have excluding Dakota County. So Dakota County, again, is probably a little bit of a negative influence on this. You see that we would have a 1.5% negative variance, so less of an increase. The overall pool would be a negative 7.7%. Again, if we think of the trend and the spread risk.
Right, I know.
And then we ran with the 5 cities that had said we are very interested in this. They would still see a substantial increase, a little bit higher than they're projected, but a lot of these cities, when you look at the number of employees that are part of this, are very, very small. So you don't have specific claims data for them. The other piece that they would have to do that's different than being part of a pool like us is because they do not have a large enough population to have, or number of employees to have the claims history data they would need. They would actually probably have to, they could still form a pool, but would have to go fully insured for a couple of years in order to get that claims data before they can transition to being self-insured through the pool. So the next piece is the history. So we had a 10-year history. So we have Dakota, Carver, Washington, Scott. As we were trying to pull this, and we're a little bit late to the game, so apologies, Commissioner. A lot of people were on spring break. And so it took a little bit to get that information. You can see Dakota, who is self-insured as well, has averaged about 6.6%. Carver County, you can see the wide variability that they've had in their rates going up 11.5%, down negative 7.7%. Down 15%, up 12%, but their average over that time period is about 5.4%. Washington County's been about 6.1%, and ours has been 5.2%. Didn't get 2015 data for all of these. Washington had 2015 data, and then we have our 2015 data. If we had included ours, our actual increase would be closer to 6% on average, because in 2015, we had a 20% increase in our health insurance rates. So again, depending on the time frame you pick the year, it impacts that. And then we normalize this data as well. So again, doing that, starting at 100 and applying the percentage increase over that 10-year period, you can see we actually have not had the same kind of trajectory of increases there for quite a few of these years, the last few years, and we've seen that in our 11 and 13%. So we've kind of crept up as some of the others kind of had a little bit of a spike down, with Dakota and Scott being the two that are self-insured here.
Can you go back? I just want to make that slide.
Yeah.
I was just curious and see the last 5.
Yeah, the last 5 years have been way different for us in the first part of this graph.
We had a stable period there for a little bit, and we'll get into this a little bit with our health insurance renewal. One of the biggest drivers for us is not just our straight claims data that the pool is paying, it is our stop loss coverage. And that's where that pool has that pooled kind of insurance claim that allows for a bigger stop loss coverage within there.
Bigger stuff.
So it's gonna, so when you have this pooling, you have a bigger stop loss then because you have a larger pool and the pool can handle a lot more of those large claimants. We're even looking at that as part of our renewal of where do we need to be and what's that math. But that pool then is handling more of those high cost claimants as a group, as opposed to us being a smaller number. So again, we have 8, that's a large number of claimants that are high cost for us. That's not as big when you're in a pool with say a Carver, Dakota County. But the pool's handling it and our rates are more stable as opposed to it being handled.
So is somebody able to analyze ours, what ours experience would have been if we would have had a stop loss that would say, it's 250, isn't it?
225.
225. It would say 400. Or 350.
We will get to that as the next part of the presentation. We have some of that. Any other questions on this one? So again, the impact, we've talked about this quite a bit, so I won't delay on it too much. And then there's the timeline. We probably need to be having a final decision of where we're going to go in early May on what this will look like for us. Right now, our plan for finalizing the JPA and the bylaws is we're moving forward without feedback from the Department of Commerce on this. So talked or got in contact with our attorney on this. And she's like, I'm not hearing anything back from the Department of Commerce. The previous contacts I have are no longer there. No one's made in the shop. My recommendation would be to move forward with it.
So with that being said, Pratt was going to carry some biblical language, didn't need to.
Well, there was other pieces, but the attorney from the Senate and the reviser said, we didn't need that if we had it in the JPA language. That's the part I would like to see how we firm up is the JPA language over that pool language. But when you get to the DOC rules,
Right.
so
Because we don't want to get bamboozled by rulemaking and
so
But the other part, they are sprinkling part. So
Right.
there is still a building.
Right.
Does seem to me along the way that changes of information are technical, you know, that does that feel that too?
Well, so from Gallagher, I don't feel like we've had a lot of change in information. So we went into this, well, there's been change in people, but what we're talking about with the legal side is there's been 2 insurance pools set up in the state of Minnesota under the statute that we're doing. And Darcy Heitzman has set them both up. And so we've been working with her and we've reached out because a little bit of silence there of like, who else does this? And she is the person that does this. And so she came in and said, this is the rule. This is the issue we need to get around. That's what helped us to draft the statute. She helped us draft that language. And that's where we heard back from the Senate and the reviser, you don't need this statutory change. And so again, when there's only 2 though, how much has been pushed on this?
So Gallagher, I think the disappointment was maybe at the scale meeting, because they did advise us, the small cities, they would have information that, which they clearly did. They didn't even show that example. And then it was that the cities before could pool, even if you were under 1,000 employees, but they would have to go fully insured pool and then go out after a couple of years. I don't think that was clear at all in December or January, whenever that meeting was to the city. So that was a change, I thought, by Gallagher in the recent meeting we saw, and I think what people expected.
I think that some of the detail they showed was different than what we had asked for.
Those summaries are whatever.
What,
Yeah, you're right. That was a little.
the 2 pools that are in Minnesota, how old are they?
I don't have a lot of details.
Have we reached out to them? Are they glad they did it? Is it worked
One
well?
is a pool under this that is for, it's like a farming cooperative.
Yep.
Underneath it. And I don't know what the other one is that's organized under the statute. I don't know if.
I hear mixed reviews. I just, so I didn't reach out to them, I got to talk with them, but I hear mixed reviews on the results of pools. And a lot of it comes down to what I think we've seen in other collaboratives where people want to make calls and ultimately the pool makes the call and people are upset because they have strong feelings on whatever the issue was that they wanted to go. And then Darcy did make the comment early on that it depends, she has one pool that works really well and one that doesn't, and it comes back to the governance body and their commitment to having meetings and talking about insurance and pooling, where for one, that I think was the farm cooperative one, doesn't work as well because they just don't meet enough and they aren't engaged enough in the topic to make it go.
So one question, we've had early on is giving up the.
Mhm.
And so then we talked about weighted voting kind of concept. If we go to Carver, Dakota, that's going to completely change that control issue. I mean, Dakota will be the first. So, the control issue becomes even more so a question if we're in.
So the language we've been using for, we kind of had a couple of different options. I more think one that's more sustainable in the future is the way to go, but it basically says, based on the number of participants you have in the pool, nobody can have more than 40% share. in that pool and it's distributed by that share. So if it was the small cities and then us and a Carver, say, we probably have a pretty equal voting share in the pool between us and Carver, and it would probably be more than 50% combined. But the cities would still have one vote. If it was a Dakota, yeah, that could change where that control would be.
The only thing though, with these numbers, I mean, pools need numbers, right? Numbers drive these pools.
Right.
If you had a Carver and a Dakota, right, yes. Potentially both, short, long term. I wonder both of those, that's when we start to see some real savings. And so that's what I like that, if we could get Carver, which it feels like that's a compelling number. If I'm them, which I'm not. Yep. Carver, here. And then you put Dakota in there, because what was that, 2,000 bodies?
Yeah, that's a substantial organization.
Carver was like, for some reason, a little under us. I'm not sure how they were using those numbers, but employees. But regardless, having those two pools of folks in this, the weighted voting, which is the governance thing I brought up way back when. Yeah, we might not have the same weight or whatever, but the savings ultimately, but we're after.
Well, the savings is important, but I think Lori hit on it. To it is that people are engaged, want to be engaged with insurance, understand it, what it provides, and how important it is to families and the organization, right? So it's great if Dakota has a couple folks, but the people that engage in it, they need to care and want to participate. We have to have those meetings the way we historically have. I think that's a really important part, as I've tried to listen to all of this, that you have engaged people that want to be there. And then that's why then ultimately they have to make those decisions, just like joint powers, right? Or that pool and how it's going to operate, understanding in the background of the own organization as well and how that is going to operate within it. So I don't know, Commissioner Beer, that I would count on Dakota. I think Carver is a much more likely based on what I think Dan's heard and where they are in their pool and those things. Dakota could be a longer term partner. I don't know that, but I would not count on them to come in 2027. I think Carver has been planning and looking at this carefully and then has to weigh, do they want to be in a more merged pool or do they want to be in?
I think the other thing we need to remember in this process is it's important to look at all the history and to think about that control and what we're doing. But I think our heads are in the sand if we think health insurance is going to look in any way like it looks now in 10 years. So we should not be making a decision about what health insurance has looked like in the next 10 years. It may even be in the next 5 years. There's systems imploding. There will not be the same options in health insurance that there were 10 years ago. They're within a couple of years, those are going to be gone. So I think it's important to think of that history and the control and operate. In some ways, I'm sitting here going, I'd love it to be a pool because we say the pool decides, sorry, this is, you're making a decision for a much bigger group and not having to try to go down a rabbit hole for one union negotiation or something like that. Like there is some differences there, but I think we have to remember health insurance as we know it is almost done.
It has to change.
Well,
But
it's
not
almost done.
sustainable.
Yeah.
But that's where, again, I'll pull out Lori's going, you need the people that, you want partners that you know are going to
Right.
engage in this, because it can very quickly all of a sudden be, how did we end up at this decision, without people that are truly trying to understand and know what the issues are within this and debate it and have the conversations, like, because it's so important to employees and the impacts of them. And so that's where, even with the Dakota, and I think Dakota would be a good partner in this for the long term, but it wouldn't just be something that we want anybody to join, because then it's just about cost for them and not about making sure that we're having a good benefit for the
Right.
employees and doing a good job of understanding the pieces of it.
Sure, but this current pool, there's a lot of like-mindedness there.
Right. It's not like we
So
have
it's-
a for-profit business, a
Yeah.
government,
No, and I wasn't saying
co-op, or,
Right.
And that's what they say the
Yeah.
benefit of
Right.
point is. You have to have like-minded businesses
Right.
and those same types of
yeah,
things. in
similar
that pool.
unions.
And I mean, when you
Right,
look
right.
at Carver, the thing and I don't know, maybe I'm wrong, but it sure looks like Carver gets a negative on their bid and then it spikes like in their second or third year, then gets a reduction in the next bid, and then it kind of seemed to reflect that a little bit. So I think they are interested, right? And that would help stabilize, which is one of the things you see different when I look at it between ours and Dakota's. It seemed more stable.
And that's actually one of the comments we heard from some of the cities is like, it wasn't all about the price, although that was important. It was that stability for planning. It's not this huge jump, this huge decline, and all of a sudden you're trying to build a budget and people are trying to build their finances on, am I gonna be up 15% next year? Am I gonna be down 17%?
I mean, budget, and being able to budget, having that ability is huge. But that trend line that Gallagher showed us and just saw it again, all of those lines are below, assuming that trend line is as accurate as it can be, which I'm guessing it is. Knowing healthcare on this trajectory is nothing driving me nuts about this, the macro side of this. It has to change, But between now and then, having even just a Carver, makes a big difference.
So having massive change doesn't inform me whether the pool is a good idea or not. It's uncertainty. That's it. It doesn't direct us one direction. I mean, our pool has had a great track record. Our self-insurance that we've had has had a great track record comparatively. Is it going to be better than that with massive change? I don't know.
I think it's two pieces. One, it's going to help spread out the risk, right? That's always the piece of having the larger risk pool, is that risk, if we have a large number of claimants one year, it doesn't necessarily mean like a Dakota, a Carver, or the cities would have large claimants. So it spreads out that risk a little bit more. And so the trend is going to decline some from where it currently is. But whether it's with us or a pool, we're still going to have those same risks of the changing market.
You know, this reminds me a little bit of, it's going to sound crazy, of jail practices and change. Like one thing with the judges, if they have a much more hardcore, we're going to put in prison. It changes the jail population. So change a couple pieces of things, and it affects the outcome. So, okay, I'm wondering, the cities typically hire young people and then they turn over and they keep hiring young people, or do they stay? I mean, Savages turn over, crazy. So, is the county more stable, and do we have higher claims because of longer pension employees, older employees? With I don't know, the practices of pool members, it's gonna.
I agree. Jeff had a comment, and I'd also look, do we know any data on comparisons for cities' tenure of employee versus counties?
Not ready to hand. Certainly something we could try to pull for resources, but that was not something we prepared for. Yeah, I raised my hand a while ago and I accumulated a few things that I just wanted to rattle off for the group. The first, I should speak on the record. Commissioner Wickham-Breckley, you mentioned the benefit of the pool would be that the pool decides. That would not be entirely correct, right? We would still have an employee insurance committee. Certain aspects, we have collective bargaining agreements that reference that in employee insurance committee. So there would still be an operation for that and a touch point with the union, which is a positive thing. And that is also something, a needle that needs to be thread as we discuss with them, because again, as we have been informed by outside counsel, and I will inform you as well, this is an issue that would be a mandatory subject of bargaining if the disgruntled union were to file an unfair labor practice or grievances. They could enjoin things, slow things down. There's also the other an aspect under the statute, if this is deemed to be a dissolution of something, the largest collective bargaining group, ID AFSCME, has a vote in whether or not an insurance, a self-insured fund is dissolved. So again, other things, the other thing that I would say, and I do this to the annoyance of my friends and family constantly, right? But things can be argued from two sides, right? The larger the entity and the more dispersed decision-making is, the less nimble it is in a changing environment. I've spent the majority of my career, it's almost 50-50 between public sector and healthcare, health insurance. I've been the HR director for a health insurance company for 3 years. That is important, and the ability to change and make changes to the plan design, et cetera, which perhaps becomes more difficult if decision-making is dispersed. The last thing that I will say, again, from my experience as an HR director for an insurance company with 500,000 members, we were hell-bent for several years back in the mid-teens, 2012 to 2014, to grow the size from 500,000 members to 1 million members. Several consultants told us the projections would eliminate my public sector health, in City Health Hospitals Corporation's $200 million yearly, and we were in the red. That would correct that. It would fix everything. All we had to do was expand the pool. We couldn't expand the pool. We could only find sick people who made things less. Like, you have to grow the right way. You have to grow with the right populations. You can add 2,000 members, but if there is a rash of something or other, that ceases to be beneficial. These are just all things to be aware of. And I just heard 3 commissioners mention the changing nature of healthcare and the need to be live and nimble. I think that one needs to kind of look at that fact from the opposite angle. It's just, again, it can be, we could gain stability and size at the loss of nimbleness and ability to adjust to a changing market. Those are my 3 points. I'm sorry I collected them over a while. I talked too long right now.
So you made it really clear what we should do.
He's an attorney, that's what they do. They go, you can do this or you can.
I seek only to give you tools to make decisions. I try not to make very many decisions.
All right, so that's the update on the feasibility study that we'll have to come to some recommendation on in May, if I'm understanding what you said. So
Can we set the meeting? And when that we would do that? We don't have a special, right?
No.
When will be done? It would be done in this-
Yes. That's what we had for you.
Okay, I just don't want.
Here, so the next step is a staff recommendation about for internet, is that at a board
I
meeting?
think that would be
No, it's during the board.
a work session. We would come back with a recommendation based on, I think, we still have some questions and data we need to understand. And then this is your health insurance renewal, so this feeds into it as well.
That's the second.
Do you want us to do that, Dave? Do you want it that?
Not really. No, we don't. I mean, so don't plan on workshops.
On those numbers that you just had up
I
there,
won't be here.
you also said the entire
Are you?
premium for cities. How come is such a big range between 1,000 per 5,000? I'm not quite sure. You
It's
put
the-
that thing up there?
He wants to go back to the total cost, what the actual premium is. And you and I had done some research on that. We all,
Do they offer
depending,
different things?
Yes.
it depends
So
what
which one are you
type
looking
of
at?
insurance and all those different.
It was all of, there you go. So like Dakota, if you take that number.
Yeah.
44,761, the current premium, divide by 2,000, we're at 22,000. Elkin Market, that, you do that same, 25,727.
So that goes back, if you remember our last presentation on this, where we looked at some of the different counties and what their costs were for insurance, I mean, we were kind of in the middle. There were some lower and some higher, but it all has to do with those plan designs that we talk about, right?
Which you still have some control over in your school.
Yeah.
So
Savage, I think, if I did the math, was 13,500.
Yeah.
Which is
Savage has
almost,
told us,
Yeah.
they're not.
They're not interested.
Right away.
they shouldn't.
Yeah, they have a good deal going.
well, it all depends how you look at it.
Because if they're set
know.
up, if they're on a high deductible plan with a 5,000 individual, 10,000 family, and they don't contribute anything into that HSA, their rates could be significantly lower per person.
Which could
Then
lead
it's-
to turnover.
It also could lead to nobody's taking family coverage, and so they're just on single employees and some of those things as well.
So this is the type of conversation like that worries me because this is a long game and Gallagher has had a different, but long game is 6 to 10 years. And if organizations are trying to get in to save money, which we want to, but with the healthcare market changing so much, like they're talking about gene therapies, we've got GLP-1s, like things are really driving costs. We're gonna see volatility no matter what we do. And I just worry, again, you have to want to do the long game insurance pool for the savings and the lower trend line more importantly than anything else. And I just worry because there's going to be volatility as we go into this. And there's some conversations that, because we've been self-insured for a while, we know how to say no to some things that fully insured haven't had to. They've had an insurance company say, no, we're not going to cover X, Y, or Z. And we need to have our partners as we go into the pool be as willing as we would be to say no and the reasons why for the health of and the good of the pool. So it's some of those things that are the nuanced challenges as we look at this and try to help make recommendations towards what's the best to do.
But along those same lines, I think was when we were sitting in the little conference room at the time where a year or 2 or 3 or 4 ago, ones were the big deal. And so I've always used that example in this conversation of, okay, the pool, one pool, shallow end, deep end, kiddie pool, I probably wrong, but different, still wet, different differences. So in this pool that we're talking about, I've always heard these service delivery and things like this, that, oh, well, this city could have X in the pool. This city could have Y in the pool. That place could have elemental P, that's still in the pool.
That's in terms of some of the plan designs.
Well, but I always use GLP-1 or formulary or things like that as a opt-in or opt-out, or because whatever the next new thing is, right? Because now there's always gonna be something.
This is one where I don't want to say I'm speaking out of turn, but the details of it, I don't have as much of a grasp on. So if you're talking about like a side plan for GLP-1s, that would be like this separate kind of addendum to it that they would have to do. And I don't know if the cost feasibility is there to ever do something like that. It's an option, and Darcy kind of spoke to that. You can do a lot of these side kind of insurance things, but it still has to be under the auspices. It may not be covered by the pool, and it may not be it may become cost prohibitive to do those sorts of things.
Well, that was the big question, is not if we've said no to GLP-1, just because it was the example of the day given today. And if we were like, no, we're not doing that, would in this pool, in this environment, would we, because we're no more than 40% or whatever the language is going to say, potentially be outvoted by multiple cities in the county?
100%.
I actually am more.
Even if we have our own plan, and there's been talk about these other plans and individuality.
I'm actually more concerned the other way, honestly, with this group, that they're going to do everything to save a buck and not do things that we're going, in our experience, this is something we should be covering for our employees. This is something that we hear from the Employee Insurance Committee, that it's a benefit that we can work in this way, or that is the way I'd be more concerned on that.
I'm gonna use the expression, herding cats. And I've been in the RTF, I gotta tell you. And been like herding cats. And I like nimble, I like having control, I don't like herding cats. I like to build a yes or no to something.
The only difference, and I understand because it's been a little bit herding cats every once in a while here. This has a mechanism to say, well, it doesn't matter if you don't, here's how much your premium is increasing. And if you want to have a discussion, understanding of it, you need to make it to the meetings. And you need to understand where it's coming from. Where RTF just kind of always gets to say, no, you have to have these premiums. You have to pay, or else you're not going to have insurance for your employees and for all these.
You're going.
So this will have a structural mechanism to avoid this relations, right? Humans are humans, people come. This JPA, still JPA, without necessarily having legislated language, actually, will have that kind of mechanism to avoid that very issue.
If they join, they are bound by the rates established by the pool, and they can say, we're not paying, period. and we kick them out of the pool and they're still obligated to pay for their claims under the agreement. It's a contractual relationship and I mean, this is the worst case scenario, but we'd be in a lawsuit saying, no, you have to pay up.
Okay, so that covers that piece. I'm still gonna come back. I know I'm looking at you. uh, With using a GLP-1, again, example, and all of the customizable plans that each entity could have really isn't the case?
They can have them, but I don't know the exact specifics of the mechanisms that they use to get them, is what I'm saying. So when we're having our plan and we go through this and looking at people that can help me out if I misspeak on this, like there's a list that our health partners equivalent would give us of these are the things that we are changing in our health insurance policies for fully insured plans. And these are the ones that Scott County has the option of you can join this or you cannot join this year. It's usually what, 5, 6 a year that we look at under those?
Now is that just formulary for?
It's not just formulary, but this is where, do you want to cover weight loss medication or no? And we get the information that nobody's covering this. And for the most part, that has guided us unless we have a specific case of, no, this is something we've discussed in the past, or we have a lot of people utilizing or something like that. The GLP-1s kind of came as a surprise because we didn't realize we were covering it the first time when we were looking at it. We knew we were covering weight loss medication. In the middle of our plan year, it got approved as a weight loss medication, so we were automatically covering it. But that was from like September to December 31st that all the health insurance providers were covering it. So a few months and then they terminated it. Well, we had just started our plan year and we're getting this renewal information and going, okay, that's where it became a bigger discussion because we're going to cover people for most of a year under this drug and then tell them, no, we're getting rid of it. But that would be one that the insurance pool would make the call on. And they have to be responsible to the pool, to the health of the pool overall in their decision. Similar to how we were trying to be responsible to the business of the organization and going, we can't afford this. It was so new that we couldn't get cost estimates for it. So we were doing our own cost projections.
They were scary. I remember those too.
All right. Any other questions on that? Comments? Keep going, you guys.
Right, so this is our 2026 health insurance renewal. As I said before, this is more informational, invite discussion and questions and what you'd like to see for the next recommendation that'll come from the Employee Insurance Committee. Again, showing a little bit more detail because you all have started to see a lot more detail in the last couple of years, especially around stop loss and what some of that means. One thing that's going to be different in here that we haven't seen before is that you're going to see 12-month renewal and 5-month renewal. So one of the things we're very, very seriously considering is adding a health savings account plan, a high deductible and HSA plan. When we do that, though, we'd like to move our insurance from a 8/1 renewal to a 1/1 plan year. So we'd be on a calendar plan year, more typical. That's what that 5-month renewal is. We have to do a renewal within 12 months of every plan year. So we have to do a short-term renewal and then we'd have another renewal there. This is the piece that we haven't sat down with the Employee Insurance Committee and said, this is what the recommendation is going to be. That should happen here in April, I think.
Yeah, we have to do that.
So that's where this kind of piece sees, and you'll see it in there, like, why does it say 5-month and what? It's coming back and forth with us.
Has the 8/1 always been a thing? Like, I mean, it's been that way since I've been here, but it's always like that. Wait, did I burn it up?
I don't even know what year it happened. It was before 1997. We've always been health plan. Decision made in the past.
That'll be good to clear that up. I mean, for all kinds of reasons.
Yeah.
It will.
So this is looking at our claims. So I'm showing 2 pieces of claims. So this is our 24 through 25 claims year. And if you look at that bottom right column, that is our loss ratio. We want that number to be below 100. And that means that on our actual claims that we're paying out, we are spending less than we had planned for. So for the last entire plan year, we were at 92.2% of our expected claims. So that's good. We want to be less. And then if we look at the next year, what is going on? This shows our information through so far this year. So it's through January, so you don't through February through July. And again, we're showing a trend of it being at 93%. And so when Gallagher is putting together these numbers, they actually add weights to this is how much we've seen in this year, and then this is how much weight is given to last year in order to our claims projection going forward. It keeps, I'm so sorry. I don't know why this keeps skipping back. You can share mine. But one of the big drivers for us is our stop loss coverage. So this is again going back a claims year. You can see the gross claim amount of 3.4, almost $5 million from 7 claimants within there for our last plan year, which our amount over the $225,000 individual stop loss. That's the amount that each individual, the plan has to pay for up to $225,000. And then we have our reinsurance was $1.88 million. Our premium that we paid was only $1.16 million. So the insurance carrier is losing on us. And so we saw a significant increase to our stop loss coverage. We look at this year, so far, it's not to that level yet, but we're also at the part of the plan year that we're covering most of the costs. The later in the plan year, the insurance ends up covering more and more of the cost because you start accumulating more and more expense. So on their projections, they are going to be a loser again on our stop loss claims.
Danny, last year, do we know after March how many had already exceeded? Was it about 3, just like this year?
I'd have to go back and look.
About the same, Lori? So you would expect kind of that same range?
Yeah, they already have them in the pipeline. You might have them.
Okay.
I don't have the ones that are close on my data.
Yeah,
That's one we get.
We're gonna be.
Yep, got it.
If you have an older employee that's on Medicare, what does that affect?
I would have to get the details on if they're on Medicare, but they're still taking our insurance coverage. It depends on which insurance is getting hit first and how much they're covering up to.
Medicare is first for us and secondary if they're on Medicare. Eligible.
So if something wasn't covered with Medicare, then it would come to ours. This shows our reserves within our health insurance fund. So we have just a little bit over $10 million in reserves. And that equates to about 7.8 months of coverage. That varies throughout the course of the year. We've always tried to kind of target that 6 months of coverage, maybe be a little bit above. These last couple of years have helped out with the claims being low, but that's where we're seeing these stop loss increases from us always being quote unquote the winner on the coverage. So as we look at our health insurance renewal. So this.
It's healthy as we're.
Yes, in general, we're healthy as a pool, but we do have the high cost claimants that are expensive. So this shows a 5-year history of our stop loss. If you look in that first year, our premiums paid were $886,000 and the stop loss reimbursement we got was $490,000. So the county fiscally, not in terms of because we didn't have as many high cost claimants, which is a good thing, we lost, right? The insurance company made money on us that year. But then you start looking at these next couple of years and we paid $815,000 in stop loss and they paid out $1.14 million. We paid $900,000 in stop loss and they paid out $1.23 million. Then we paid $1.2 million in stop loss almost, and they paid out $1.88 million. So they've been a loser in the last few years and have been increasing our stop loss coverage because of that. And that is a major, major driver of our health insurance increases right now.
And their look back window is 3 years, so now we have 3 bad years.
Yeah,
We don't have a year to offset.
so we're gonna go up. with
So
that.
we used to have, not that I ever participated, but an employee wellness. Big program.
We still have that?
Yeah.
Wellness, and then also through our health insurance provider, and this is one that I don't know as much detail. We do things like disease management and stuff where our health insurance provider is actually reaching out to make sure people are on their medication. If there's something coming up, making sure they're getting to their doctor and some of those things so that we don't have people that are sick, not doing anything, and then having to come back and it costs us more as opposed to the disease management side of things.
You'll see people down in our workout group, if you walk through there as part of it. We offer, Move It Day will be coming up, I'm assuming next month. We do things in October. We now have our little winter weather thing where you see people down there doing a few things. So we're trying to promote those types of activities and people, you'll see wellness posts come out about things you can say.
Nice pickleball court.
Yep,
That's
it's a
great.
nice court. Yeah, it works well.
So, okay, I don't know what the health club reimbursement is, some people, they go X amount of times, they get reimbursed or something. What is that and why have we never done?
We've debated it multiple times at the insurance committee, but it's a cost to do that. And like some other types of coverage, we've chosen not to supplement a small subset. We like to go to a club across the whole membership. So it's been an insurance committee discussion. We have determined not to do it as a group.
My recollection is also it doesn't pay for itself typically. We don't see a significant change in health quality from doing something like that.
I think many places have stopped doing it because they didn't see.
You are correct. Many places have stopped doing it. Many plans have stopped offering it. What they offer is stripped down now in the last 2 rounds of bargaining. 2 unions, the human service supervisors and AFSCME, have specifically brought up or attempted to bargain some kind of wellness credit directly with us. Like if somebody shows me that they went to the gym X amount of times, I'll give them back money. I'll never agree to that new language. But in those conversations, they have opined that something that I don't know if it was something that was discussed at the EIC, but like Orange Theory Fitness and you get that much back. That's unacceptable. They would like a bigger, more robust rewards plan, and it doesn't exist. It's not something that's in the market that we could give them. So it's a product that is falling, that is disappearing from the market, I think in part because what you have is not giving you a robust benefit necessarily. It's become this sort of sideshow, which is a shame because, when I was HR director for a health insurance company, we gave everybody Fitbits and there was walk-in and it felt like we were making people healthier, but it has not survived the market.
And I'll tell you, if you go downstairs, there's nice equipment down there and the people that use it really like it.
What we're doing here directly, I think, is a far better way, again, to try to engage employees, get people voluntarily to come to a building, collaborate, see people, et cetera. Far better than a program run by a third party to give back rebates that doesn't appreciably reduce our costs or increase outcomes. But that's just my opinion.
And also Les is a great pickleball coach.
And remarks promoter.
Yes.
Probably start seeing knee surgery.
Knock on wood, quick.
Achilles and knee and thing.
All right.
You love pickleball.
So this number right here for our 12-month renewal, that 853,000, right above that red box and 50% is the increase for our stop loss that we have quoted for our 12-month renewal right now. So this part of it, I'm trying to show apples to apples, what we typically would see. The 5-month renewal gets a whole lot wonkier and isn't as good on the apples to apples comparison.
And this is at the 2.25. This is at 2.
Yeah, at 225. Yep. And then this one, just real brief to remind you, this is our aggregate stop loss marketing. Do not look at that 591,000. That is what we have to get to before aggregate stop loss kicked in. We're only seeing a $2,200 increase in the aggregate stop loss. But I show this to keep in mind that because I said, I have asked the question, what if we went to $700,000 or whatever, like going crazy with our individual stop loss? You see that flipped around on your aggregate stop loss then, right? So you're not taking as much on the individual, you're taking more on the aggregate. And so because of where we're at, so that'll shift. It probably wouldn't be a loser for us if we increase that stop loss, but going to 500, 600,000 does not mean that that aggregate's going to stay low. It's going to start making up for itself on that side of it. We did look at stop loss. So this is not quotes going forward, but this is to show what we would have had historically if we had had a higher stop loss rate. So if we had just gone up to $250,000 in specific stop loss, in 24, 25, we would have had $111,000 in savings, 77,000 the year before, 188, 172, $178,000 in savings from the premiums versus what we would have had to claim. So you can see the premium savings over here in this left column next to the year, the additional exposure that we would have had to pay for out of this, and the cost and savings. So number of claimants that would have been within that band, one each year really, and the number of claimants that would still be over. Our premium still would have gone up each year because there would have been probably losers. We probably would have been losers in the financial side, but that's what the savings estimate would be. Next one down below goes to $275,000 specific stop loss. Again, see savings in the more recent years, we'd be picking up more of it, but in the past years, we would have had more savings on that. And then again, going up to a $300,000 specific stop loss, we would see $700,000 in savings, but we would have been picking up $451,000 in cost. I do want to continue going down this path though, because I do think there are some savings there. We have a healthy fund balance. We need to play with that and have more debate and discussion on it, but we have been asking for, we need specific stop loss increases.
How many months are we at right now?
7 point. I just showed it.
6 is our target.
6 is our target. Now, some of that may be what do we do for these 5 months? Because if we don't want to do 2 increases, do an increase and another increase, we'd have to use some fund balance. That's the piece we haven't talked enough about though.
So why do we, what, you see 5 or 6 is our goal? 6. And then in this new pool, we're saying 3. Why us 6 now and saying all our pool partners 3?
So we have always been higher. Gallagher says that we don't need, 3 months is enough for premiums to come in and cover the payments as more premiums are coming in because of the delay in billing. We like the flexibility of being able to say, hey, we are ready to take either a little bit more risk in this year and not be as high as Gallagher's saying. And this is to some extent art night science. If you look at Health Partners renewal projection for us, they were at something like 7.6%, and Gallagher was at 9.94% for what our expected claims were for next year. And we're kind of sitting in the middle of that at that 8.3% where it's at. We have gone lower than Gallagher before in the past. We're saying, no, we have enough fund balance. You're inflating the trend more than we think it needs to with Health Partners saying this. And we have enough fund balance to take a little bit more risk of that without taking a huge risk. And we've done that in years before.
Yeah,
Right.
we've done that consistently.
Yeah. And lower than Gallagher.
They said, and,
Yes.
We stayed at 6 months despite them saying go lower. That's just been what our committee and style has been, and it's worked for us.
And it's worked for us because we got a scare one year. So having it at 6 months was a good thing.
So based on what you know right now, if we didn't change it, what would you change and stuff?
I would be looking at going up to $300,000. I mean, that's my gut on this. I asked for this information on my own outside the group. I had to miss our last meeting. So Lori and Jeff and Janelle haven't had a chance to weigh in on it. So this is just Danny speaking, not the wisdom of the group, which there's a lot more wisdom in that group than you get from me. Those individuals, a lot more history on it, but we've done it in the past. When I first got here, we increased our stop loss by 75,000, 100,000. And it helped us and we overpaid for a few years, and then it's been helping us again. We're seeing those stop loss increases go up and up and up. We take on more risk and handle those smaller claimants. But when we get those $1 million claimants, the pool is still, or the reinsurance is still covering it.
Would we ever go crazy and go to 400 or 500?
That's the piece that I've never had a good enough handle on. What is that going to do to our aggregate coverage?
Because
Because
look at all those claims, that there's got to be equation.
There is, but the aggregate stop loss is the piece that I don't know how to do the equation on. So the aggregate is looking at a pool, okay, if we go up to 500,000 and we have 10 claimants in there, our aggregate's gonna go through the roof in there. But if we only have 1 or 2 claimants, it's gonna be that individual that's hit. Yeah. So that's what we're asking for more.
Because I always think you lose when you buy insurance, somehow or another. Right?
Yes, the big X factor, and Lori alluded to it earlier, these gene therapies that are out there. Where if we have 6 people on the gene therapy and those are $1 million a pop, that's $6 million hit to our plan. If we have a really high stop loss and these gene therapies are starting to come in, we're gonna see that turned around our aggregate going, you're blowing through your aggregate coverage every year. You have to take on more of this risk. So yeah, that, you do lose on insurance and it's designed that way because you need it to handle the big spikes in those years that you would otherwise lose on.
Members, Gallagher said, the stop loss providers want 85%.
I thought it was 70%.
That was 85. Anyway, they want a much lower number than to us as the other part of that equation.
So this is just looking at the number of claimants we had in there. So if you look back to 21, 22, we had 5 claimants that were over that stop loss, a couple by not a ton of money. 22 to 23, we had 4. 23 to 24 though, and this is when Lori's talking about that 3-year look back, we had a lot of people, and this is where we increase that stop loss. We're taking it several times versus these couple of years here. We're not taking a hit as many times. So it's just one person hitting within that band, not as many people.
So if we moved it to 400,000, that 23 to 24, we would have only had 4 people collect, right?
If for 23, 24, we would have had 1.
Then if,
At 400.
Oh, 400,000, sorry. I was gonna say
400.
Yeah.
So if we moved it to 400, if you added all those up, so you'd have 200, 300,000. How much less would our premium go to take care, and then the difference between those other ones?
I don't know the amount for a 400,000. I'm guessing our stop loss premium would go down by another couple $100,000 going up that high. But it's that risk then we're
It would
taking.
go almost down by half.
I don't know that. The other piece of that though is our aggregate stop loss is going to go up. Because we have the number of claimants that now are hitting our pool that we might be above that 20% increase on it. This is the break-even analysis that Gallagher is helping us with.
So you're gonna do the final.
Yeah, they're gonna give us quotes for these numbers that we're looking at. They are probably, I'd say, more risk averse than I think I am and Commissioner Wolf over there is. Probably more in line with the rest of our ER team that is a little less risk averse, based on where we're at. And that's where we find that mesh and really have the insurance committee, but.
So do you think 300 represents the best?
Well, if you look at Gallagher, they're just going up by $25,000 increments. I think I would at least like to see numbers at 400,000 and 500,000, like Commissioner Wolf saying, to say, what is this? I don't think we should go there. That is too big of a bite for us to do in just one jump.
I think 300,000, we do want to get that.
Yeah.
That looks like
The reason I want to go that high though, is not to actually go there. I want to see what it does to our aggregate so that when you talk about this math that we can kind of do on our own, can see where that middle point is. And that may just be more of my nerdy exercise in trying to figure out the math behind the stuff than actual value. So.
Have we replaced the retirees on our insurance committee yet? Be great if we could do that. I mean, that was the goal, right? To replace.
That's my
Yeah.
understanding,
Yeah.
yes.
Thank you.
Really?
Well, I mean, if that was the goal.
I wasn't there for the discussion, so. Were you there? Or, I'm sorry.
No, no,
Okay.
they don't even want me there.
That's
I
nice.
just, if those seats are remaining, it'd just be good to have somebody in them. If those seats are gone, that's great.
So who just, Dick is gone and,
Yeah.
Kenny's gone.
Penny Scottsville.
Yeah, and who else is gone now? The three?
Oh, there were two.
No, there's just the two feet.
And do we need them back or,
I think that was always the intention.
or somebody to represent those?
just for bringing in maybe some of the newer retirees that were
So you don't want those two guys back?
This plan.
I'm just asking, I
Well,
don't, because they're gonna
It was
wonder.
a term thing and.
You're gonna
kind
get
of
a
term
call.
thing. So, no, and that's what I explained was that we're looking at getting.
Yeah, it was never,
Retiree insurance. I'm just wondering, it
I don't think
doesn't,
it
does
falls.
it?
Well, we talk about retiree insurance at the insurance committee. So we do have the right retiree insurance plan because under statute, if you retire from a county, you can stay on the plan. So we have that.
And they were,
What am I trying to say? The supplemental plan, a supplemental plan, or we have people who still qualify to have us pay for insurance based how long they were here in
Right,
previous years. So we still have that group too that's interested in.
so you want somebody on that plan and then you want somebody who's more a COBRA or supplement person?
Right, well, both of them represented, one was Medicare enrolled and on one of the advantage plans or supplemental plans, and then the other was, both being 100% county contribution to the plans. The other was Medicare enrolled, but still on our open access based plan. So we do have a good amount of employees that are still on, the plan, which is our active.
Yes, we will actively look to replace them. I think there was some debate in previous insurance committees about sometimes they dominate the conversation and current employees felt like we want more say in what we're paying for and what we're working for. So that was some of it, but again, we are committed to have them represented because they are part of our.
yeah, we also wanted some folks who might be a little bit closer in
Yeah.
time
Yeah.
to employment. Having been on a board like that a long time, what sometimes happens, it becomes a lot about the history of what's happened over the last 15 years and not necessarily what's happening in the market right now.
Not the future.
That is not a comment on any person, right?
I totally support that in all our groups. That's great.
All right, what else?
So this is showing, like I said, that 5-month renewal. So this shows about a 4.2% increase is what Gallagher's recommendation is. So you see expected claims trend, Gallagher's at the 9.9%, Health Partners at 7.6%. This is where Scott County threads the needle and figures out what we are comfortable with. This is the comparison renewal though that I wanted to show. So this is that 8.3% down at the bottom. Again, the reason this shows different than the trend that we saw for the feasibility study is because one, it's 1/1/27. The other is, says it's using the same claims data, all of these fees that we have actually locked in information on that for the pool, they're doing an estimation of these are what the claims are going to be. So that'd be the difference in why you're seeing that. Because this, I was sitting in the presentation to scale, going back and forth and trying to understand why these numbers were different. So that's the reason why. But the big thing is, what is it going to be for employers or employees? But one thing to be considering, I'm kind of one thing to take away and plant in your brain about considerations for the next conversation. So this one shows our base year for a current plan, estimated base plan renewal at a 4.2% increase. Again, we need to figure out where we're going to land in recommendations for this. But a decision that will be coming up, if we go down the path of having an HSA and a high deductible qualified health plan, is what that impact is going to be and what are the levels we want to set it at. So this shows a couple of different scenarios. We need to work up different scenarios for decision-making on this. It shows a 34 individual, 6,800 family plan, and what the impact would be of that.
So will you go back and explain again what an HSA is versus our insurance?
Yep. So we have a traditional health insurance plan. It has an out-of-pocket deductible. It has co-pays, but that deductible is pretty low within there. What an HSA is, it's a health savings account, which actually isn't really the plan. The plan is a qualified high deductible health insurance plan. And so that means when you have a health insurance plan that meets certain qualifications and has a high enough deductible that you are eligible to use a health savings account to set money aside to pay for those years when you have higher out-of-pocket costs than you do in a typical year. When you switch to those, typically the premiums are a decent amount lower than what they were on a traditional plan. But the idea is that you reinvest some of those savings, especially for an individual, into that health savings account. The other incentives with that is those health savings accounts are portable. So it's not a Scott County one like some of the other things that can't move around anywhere. They also, if you can invest up to the cap of those, but they can be used in retirement as a retirement vehicle as well within there.
So different than our health savings account now, which is only when you retire or leave the organization. This is portable,
HCSP.
HCSP or whatever. This is a different
Yep.
program, right?
This goes anywhere, but yeah.
It's your personal health savings account to spend towards healthcare costs.
And you still get your checkups, right, covered, just like you would under our
Preventative
normal
care.
account. Your preventive care is still covered.
Care is covered, but everything else is out of your pocket until you hit your deductible max, depending on the plan type. So that's where it feels like more of a hit to people because they're paying, because they're lying to their premiums that just come out of their paycheck. But every time they go to the doctors, they're having to pay that bill until they hit that deductible.
So the $3,400 is a deductible for a single person, is $6,800 or a family or something? Or,
Yeah, That's
right?
correct.
And then the other one is 5,000 and 10,000, which is comparable to what the other counties.
Yeah, so we have some other counties, not a lot of, I've seen places that have that 5 and 10. They almost always have that 34 and 6,800 for people to go into. That's a pretty big jump in how much you pull out of pocket to go to 5,000 or with a family, $10,000.
And if we're going to continue to offer the base
Traditional.
insurance, the
Yeah.
traditional insurance, is there any impact to people on that plan if we have an HSA?
There is no impact.
Which is interesting because that was the question and answer 3-4 years ago. Knowing things change in that small little conference room of like, if we offer that,
All the healthy people go on that and it'll make.
this is a great investment vehicle, so if you're healthy.
The way you have to think about it is when we're getting our evaluation done on this, they're looking at all the risk in the plan overall, right? This is what you should expect to pay out. This is what you should expect to have contributions for. When you look at our actual current plan deductible, 7,500 and 1,500, but then they're right above for the current plan, and that 34, 6,800 to an individual, that is a significant jump in money. When you look at the insurance claims we're paying out for those higher cost claimants and things, that is not that significant of additional amount that we're actually paying out. So the plan is not looking worse because when you're looking at our high cost claimants and our claims experience, that is a pretty minuscule impact on the overall plan. They're still looking at that based on how much cost this person had, knowing that person could jump back to a regular traditional plan if they had a bad year, right? So that's not going to shift what it is. Our plans are going to increase in step with each other. If we're at a 6% in here, all the plans are going to increase by 6%. The difference is in that employee, for that day-to-day employee who doesn't have a lot of healthcare costs, is going to be taking on a lot more of those day-to-day expenses with the assumed benefit of being able to actually get some savings and invest those dollars and have it be portable with them versus all that money is just going into the health insurance pool and I never get to touch it if I leave the organization.
So to clarify, you wouldn't offer both of these at the same time.
You could be. I don't know that we have gone through the scenarios. Other places have a couple of different tiers for it.
My kids don't have both those options.
So what about the dynamic of all the sick people that stay on?
The traditional, then they're going to pay a higher premium for that, but they'd still have it available. And for us though, as the employer with the health and the insurance pool, when you look at it in its totality, the difference between us paying or them paying $7,500 or $3,400, that few $1,000s difference is not a major decision-making point for us in terms of the health insurance pool overall.
So how does that work then? So the premium for a family on, let's say, the 3,468 is $2,900 in total. So the county pays 2,200 instead of 2,400. Am I reading that right?
Yep. And actually, this number hasn't been inflated for the increase.
Yeah.
So
And then the employee pays 734 versus 813. Then how do they build up their account or whatever that is? How does that work?
So there are several different mechanisms. One, a lot of people will take the savings, or what I used to do is take the savings between that and put that into that HSA. Frequently, there is an employer contribution. So if you run through the savings and kind of apply this overall, there's a dollar amount in annual savings for each employee that's on these from where they had been before. There's usually some share of that savings because the employer, if you look at a single employee, we get 90% of the savings. For the others, we get 75% of the savings for each employee or family that is on that HSA. There's usually some level of sharing of that. And that is usually a direct placement within their HSA to help them build it up so they do have coverage. Because in general, these plans are less expensive to the plan overall, to our health insurance pool. And so it is an incentive for us to get more people onto that because it is less costly to the organization overall to have people on those plans.
So whatever that projected shared savings, which we don't know yet, taking it, you would share that between the county and the employees?
We had some,
understanding this correctly?
well, we haven't come with the proposal yet.
That would be a mandatory subject of bargaining,
Yes.
right? So we could say we're gonna do this for you, and they could say that's not enough.
Okay, and so for a young family to get up to $6,800, right? I mean, you have one broken arm, you're there pretty quickly or something, right? It takes, how long would you estimate it would take Barb Dahl to save $6,800 under a family to have it in her savings account?
I haven't done that math yet.
Okay.
If
We don't know that yet.
I were someone going to that though, and this is dependent on every single employee and what their circumstances, you try and get up to that amount really fast in the first year or so. And then you have a smaller contribution that builds up, right? Because you want to be able to have that 1 year of coverage, because the fallback is always, okay, we had a really bad year. Was it a one-time bad year of a broken arm, or was it we have now a condition that we are treating for the rest of this individual's life that we need to go on a traditional health insurance plan for? Or have a lower deductible plan because we want that lower premium and less out of pocket.
So we haven't done the calcs yet on knowing how long it would take a family to get to the 6,800. That's part of your analysis yet to bring back?
Yes.
Yeah, it depends on our contribution.
Well, it's funny, but I mean, if we did nothing, the savings is there in that chart. It's on the far right. So if I was in the family, I'd take that $80 a month, put it away. That's going to take me, if we're just having them self-fund, what, 4 years?
And that's up to them. They might not do it.
Right, right.
Most people don't.
So that's
Spreading
that's
it
how we initially talked about some of this at the insurance committee, and that is collectively our largest union's question is how much are we gonna send them to go into this plan? She answered it, and from Gallagher answered it saying, well, typically there's a lot of employers who just have you use your own savings, like the HSA is your money, you're not putting it into insurance that every year is just gone, like you're now building a savings plan that's your money that you can take, and people can build a lot of money in those savings plans. So it's a really big choice point. If we're gonna, as an employer, share in that savings of 75-25, or just have them take their 25, which is savings for them, and they get to put that $80 away. That's money they don't have to spend anymore.
It does come down to a strategic question. How much do you want to incent behind an insurance plan? What is our, because again, we realize the savings for every person, but different things are differently situated. That's something which we have not fully talked through, but it is a part of this decision is, are we attempting to drive people? Or are we attempting to see what the natural forces, where that outs? The other thing I want to just throw out there, because it was mentioned, I am not a believer that this is a bait and switch. I know a little bit about insurance. It's kind of the third time I've mentioned it in this meeting. The employee insurance committee is very much concerned it is a bait and switch. Any of you elected officials may get questions if this is the direction we go. And I think we have very good answers there, right? This is not This is not just being driven by finances. This is something that we want. We have plenty of folks who are single, who are young, for whom this is objectively beneficial. And there may be an outcry for it. But I want to be really clear, while we may not in this room agree that it's a bait and switch, that is a commonly held belief, and we should all be prepared to speak to that or be questioned about it. I want you all to be prepped for that. I've already gotten it a few times, Laura, I'm sure you have.
It was, and it was brought up at insurance committee, but she explained it, it's a paradigm shift. Insurance is changing greatly and HSAs are very, very common. It's more uncommon for us to not have that at this point in time.
And we're the only metro county, I believe, that does.
Yeah.
Well, there's a lot of private businesses where that's your only options. You don't have the traditional.
So that is also then, that's the other side of the worry. As he said, we have both ends of the spectrum. The other side of the worry is when there's that, what's the word? No, the selection, the alternative, the.
All adverse selection.
Adverse, thank you. When you have that adverse selection, at some point in time, does it get that 98% of your people on HSAs and then you have your 2%? So again, it's not adverse selection in that because they're all pooled together, the costs will always be pooled together. Your claims are your claims, and then they figure out the pricing structure based on the two plan types. But again, over time, what other companies have seen is that people really like HSAs, and maybe in 10 to 12 years, you have a issue because so many people want HSAs. That's more the natural selection of how these come.
And the concern you get from employee groups, not just here at Scott County, but other places that I've been where we've had these discussions, right, is your union leadership tends to be in a certain, they've been around, yes, they've been at your employer for a little while, they have a family, maybe they got into public sector service because of benefits, they've got a spouse who does something else with their life. You have oftentimes people with outsized voices in that decision-making process who are biased toward the existing PPO plan and are more susceptible to the argument that, hey, 97% of the people are going to go in this, and then in 5 years, your premiums are going to be through the roof again. I echo Danny's point. I think that is sort of an overblown fear, but it's a fear that we should be prepared to speak to because it does exist. And it's going to be overrepresented most likely by decision makers in those groups, just by the nature of demographics, right? This is an HSA and a high deductible is not a plan for me. I have 2 young children who have health issues. That's just not, it's not for me. And if I am a decision maker, I'm going to bring that bias. And so it's something we want to be prepared for. Not a reason not to move, but just to be prepared to speak to these.
The other thing I'd say, when we talked about this a little bit at our last time, we talked about the feasibility study. If you want to talk about savings to health insurance right now of what we have available, it's increasing the risk pool or it's doing plan design changes. This is one of those plan design changes that we can control, that offers a benefit to employees, that reduces some of our costs. It's not going to reduce our health trend line, right? It's still going to be going up. We're going to have those same claimants, but the cost we're putting in is going to go down the more people that are on an HSA. We're not going down a path of eliminating traditional or anything like that, but this is a less costly plan for us as an employer for the average employee.
I just want to say one other thing about if I sow fear or anything, I apologize. Right, this is not a surprise, right? We bargained at the table with all the unions. We adjusted insurance language in 2 different ways with all the unions to allow us the opportunity to add new plan types without bargaining and only have to engage the union if we're going to remove something, which is frankly what we'd have to do anyway under the labor law under 179A. So again, I don't mention that to talk about my contracts. I mention that to say that this is something that is on the union's radar. Employees are well aware of this, that this is a direction. So if I've made you a concern, I was only trying to prep you for pushback, not to discourage anything.
I just want to revisit the whole idea of the HSA will not diminish the traditional, whatever we're going to call our current plan, our traditional plan, nor will it raise the cost.
Because you have to look at the whole pool of claims.
Okay,
You have to look at the whole pool of claims, right? All of our claimants are coming from the same pool, all of that payment. The only difference is how much is coming out of pocket from the employee, that lower amount. We have a little bit lower premiums coming in, but they're taking on more of the cost, and that's what it's geared for, that gap that they're now taking on. It's basically, I think Lori used the term, it's like their own individual stop loss coverage, right? They're taking on more of that initial risk. so that on those bad years, the county continues to take on the risk. But if you look at the difference between a $7,500 deductible and a $3,400 or $750 deductible and a $3,400 deductible, that is a very small amount for the size of our insurance pool of additional risk that we are taking on from having those people on the individual plan. You'll see, we're not talking about the $10,000 claims in here. We're talking about the $1 million claims. So that is why it doesn't have a significant risk on the pool. They're still basically pricing our pool with all of that risk there.
Well, and understanding things change, but again, going back to that question, maybe it was 3 or 4 years ago, in that tiny little, before we had this,
I would say it was more like 6, 7 years ago. 3, 4 years ago, we were talking about this and said, we can't do this now, but we need to start planning for when we can do the HSA.
well, I mean, it's a great option. Well,
It is a great option.
Well,
it's a great option to have.
It is, it's a good option.
it is. My reluctance is just, it's like, holy cow, where have we come with health insurance the last 10 years?
And so that's where, whenever, like, I smiled at the question, because that is what we've been told. That they will look at, that actuaries will look at all of our claims and we will get rates based on all of it pushed together. I don't know until we see what happens with claims, and we just don't know. So I never want to sit here and say it's gonna go down, because I have no idea what is going to happen.
We would have to make a shift in how we do it. When we see an increase to our health insurance, it's not like we go, this plan gets this much, this plan gets this much. We apply the increase across the insurance claims or the insurance options and increase them all. So we would have to make an active choice to say, nope, the individuals that are doing this, because that's where all of our high cost counts are, we're giving them a 15%. And I don't envision us doing that. That would have to be an active choice, not a structural problem with the plan.
So can I ask a dumb question? Since we have 6 months, is there enough in that 6-month pool to create a deductible pool where we could raise the deductible of our insurance?
If you had $5,000, you'd need $4 million for the whole program.
To add it to the,
To be able to give people
The
the
one time, like, fund
So
your,
that they would have the funds sitting there.
Deductible pool, the funds would be sitting there.
so that is a method that places do in order when they're trying to get people to go on to an HSA plan, eligible plan. So what they'll do is they'll say, okay, if you move to this plan in the next year or the next 2 years, we'll fully fund. A lot of times it's just for, I'm consulting the outside expert that I had when I was doing this Thursday night of my wife, who has been part of this. They might do it for a year or two to fully fund it right there. But those are your 2 years to get in. They don't do it as much except for the regular contributions to the HSA for employees. So it's a shift to try and urge people onto it. So I've done some back of the napkin calculations that I'm not ready to share here of what some of these options look like. I told you I wasn't ready to share, honestly.
I don't know.
But she said you might.
What calculations are those?
Looking at it based on number of people on each of these plans, what would be the savings? And what would be the cost on some of the
I was
funding?
even wondering, could you raise your regular insurance deductible up? You had a pool to help people, would there be a savings there? I don't know, I was
So
just thinking out of the box.
We would have to pay the deductible then out of the insurance
On
pool.
the pool, that's what I was wondering, is there enough to create a pool there that you could raise it, what we've got well paid?
raise, like generate, not raise.
I think
So I got a
they've
question.
talked about it more as like, we decide what we're going to invest in single and family. And then whatever the county's gonna invest, you give it to the fully insured, how it needs to pay out, and then you give it to potentially the HSA with backfilling their deductible area. But you wanna be careful, because again, over time, you wanna have a savings, so you don't wanna overstep where you're now stuck with more than what it's gonna cost us more over time.
I was thinking the same thing. You said it's like an individual stop loss thing. Which to me, then I would go, well, I'm not really insured up to a certain level. I'm completely on my own. And so a person that thinks that way, would they take less well care care of themselves? I mean, would they be less likely to go to the doctor? And I mean, what, their studies show that that's for the overall health, that's bad. I mean, in other words, it could be bad for the organization, bad for the individual.
I have not had any of that data shown to me that people are less likely to use it. So preventative care is still covered under this at no cost to the employees of those preventative services. It's those things that are, hey, you need to go get this looked at or get that looked at, which I haven't seen data, and I don't know if you've heard anything on that, that people choose then not to because they are on the high deductible health insurance.
I don't have broad data on that point. I've seen some niche things from like a decade ago, but it's a very good question. It's a good question because that is an anecdotal argument that you get, right? We're going to do this. The young, the singles who are healthy aren't going to go to the doctor, which is a little bit crap because preventative care is covered. Checkups are covered, and that's the most important thing. But right then, you're going to have a greater number of people sick or long-term illnesses, and it's going to cost too many money. I've heard that for 20 years. I've never seen it really happen. But again, it is a common sense anecdote that you hear, right? If people are on their own to take care of themselves, they won't go to the doctor as much. They'll get sicker. They'll be absent more. We'll have to pay more overtime or hire more people. Again, I have not necessarily seen that in numbers. And so when an AFSCME or someone comes at me with that, I have to ask them to show me those numbers, right, to prove that to me. And if they cannot, right, it is an anecdotal story which has some resonance with me, but it's not data that I make a decision. I'll do some research as well because I don't know what else is out there. But I've seen things like this on specific insurance plans, HIV special needs program, etc., where we had grant money.
I'm not making an argument on that. I'm asking.
I think it's a very good question too. It's a thing that people focus on.
And I think that is a belief among some of our insurance committee members, because we have talked. But it is anecdotal.
It is.
And then we did, it's been several years now, but we did ask them, how much do people make in these banks? And it was lower than we would have expected. The HSA is like, we expected some of these organizations that have had them for years, we thought they'd be doing 20 to 30,000, but it averaged around 8. And again, it's because you're using it. So again, it's not that it's bad. We just, as an insurance committee, thought there'd be more money in those.
I think it also depends on where you're at, right? So if you're part of a plan that only has HSAs, you might have your younger years of employment where you're building it up and putting money aside. And then you have those years where you're dealing with health issues and that sort of thing. And then maybe as you're near the end of your career, you don't have kids on there and that sort of thing, and you're continuing to put the savings in based on where your income is, or you do have health insurance costs and you're spending it out all the time. So what?
It doesn't take much though. My husband has this and we utilize this. And so does that mean you can have one like MRI for your kid that screwed up their ankle and it's like $1,500. And so
My son just started a medication that
Right.
costs $7,000 every month. So my wife's HSA is gonna be up there real fast, so.
Okay, so we're gonna have more announcements.
More
We're
information.
gonna
This
bring
was-
back more information on this one
Like
as
the
well.
Chinese water torture.
And this one we do have to make decisions on because our plan renewal is 8/1, so. we
Right.
have to make decisions, and then there's quite a bit of work just
Yeah.
between now and 1/1, if we're gonna make all of these changes within a new system that we just finished changing.
So what's the deadline, Lori, for that decision?
We typically have the decision from the board second meeting in May. The very latest would be the first meeting in June, because we gotta have time.
I think we can be ready with it.
But you're coming with a recommendation. We didn't really even hear your recommendation. Yeah, we're looking at options.
So that's what I'm saying is, when will you bring back what this would look like, what the cost?
We just have to pick the date in May, and it's kind of, do you want the slow water torture of 2 health insurance presentations or 1 at each?
So we have to talk to the insurance.
Yeah.
Next week.
So the first week in May, we should have a work session on it, and then May 12th, if we have to have a second one, right? And then
One work session.
one work session. So we'd come back the first week of May and then have some action the second week of May. All right, that works.
Yep. All right, and you can be done listening to me. I know.
Thank you. All right, anything for Commissioner Round Robin, this board meeting? Commissioner Muir? Commissioner Aller? Commissioner Wolf? Commissioner Brecky? Commissioner Brennan? No. Okay.
So one thing I was thinking, is- and I just want you to think about it for the future. I was proposing that the round robin be closer computers. Now, I know that's not, Jody feels strongly no. But I just want to throw it out. To me, I think it's good to have a little bit of free flowing. Not asking for any comment. Yes.